Thank you very much. And thank you for inviting me. So during this presentation, we're going to talk about a quite innovative approach to ventilator patients, and it's called the flow-controlled ventilation. So I will briefly discuss what exactly is flow-controlled ventilation, what are the effects of flow-controlled ventilation, and how to apply flow-controlled ventilation. And I have no conflicts to mention. Now, we all know nowadays that if we want to ventilate our patient, we have to do it in some quite long protective way, just to avoid the occurrence of ventilator-induced lung injuries, meaning that at all times we have to avoid the occurrence of paratrauma just by monitoring our airway pressures. We have to avoid the occurrence of volutrauma just by not using excessively high tidal volumes. We have to avoid the occurrence of atonic trauma just by using that right and ideal beep that avoids the cyclic opening and collapsing of the airways. And we have to mind our driving pressures and avoid overinflation. But pretty recently, another culprit has been identified, and his name is high flow. Now, when we talk about flow, what actually do we mean? We can define flow as the rate at which a given strain, a given deformation into the extracellular matrix of the lung occurs. And the higher the rate of strain, the higher the rate of administering tidal volumes to your patients, the more the resistance will be and the more energy will be required to overcome that resistance. Now, inevitably, at least part of that energy, it will be lost and it will dissipate into the lungs. And at least according to some authors, because there is a little bit of discussion going on there, but I will come back to that later. According to some authors, that dissipated energy is also identified as a bad guy causing ventilator-induced lung injuries. Now, what does flow-controlled ventilation do? It controls both the in- and expiratory airflow, and by controlling that airflow, it minimizes the mechanical impact from the ventilator on the patient's lungs just by decreasing the dissipated energy and by minimizing the mechanical power. So in that way, you have to consider flow-controlled ventilation as a kind of lung protective ventilation. Now, where did the story start? It all started with the design of a very special single lumen tube, the tri-tube. This is a single lumen tube with a very small diameter, and this was specially designed to use during tracheal surgery. The diameter of this tube is so small that passive expiration is not possible anymore. So there is a need to actively expirate, and this is what this kind of ventilation can do. It can apply a negative pressure at the proximal end of the tubing. And just the use of this kind of ventilation, just by coincidence, they also observed beneficial effects on the patient's respiratory mechanics, and it is where more and more interest in this kind of ventilation was born. Now, what exactly is the difference between flow-controlled and the more traditional ways of ventilation? When you look to the right side, pressure-controlled ventilation is related with a very rapid increase in airway pressure, together with high decelerating flow patterns during both in and expiration. When you look to the volume-controlled ventilation, there is, during inspiration, a constant flow, which is good, but the problem again remains during expiration, decelerating flow pattern. When you look to the flow-controlled ventilation, you can see that during both in and expiration, the flow has been kept constant, and this results in a linear increase and decrease during expiration in intratracheal pressure. Now, what are the effects of flow-controlled ventilation? And most of the results are from studies conducted in animals. On this slide, you can see the regional ventilation pattern of porcine lungs, and the dark colors, they represent regions of the lung that participate early into the ventilation. And you see that when flow-controlled ventilation was applied, it is much darker, meaning there is a kind of recruiting effect due to this kind of ventilation resulting in better oxygenation. What else? We can also see that there is an improved ventilation efficiency. The purple color is the color of the flow-controlled group, so we can see that despite lower minute volumes, there is more efficient elimination of carbon dioxide and also together with higher oxygenations due to the recruiting capacities of this kind of ventilation. What do we know in humans? Well, this is a study conducted in humans with moderate ARDS and, sad but true, no significant differences in oxygenation or area pressures. And maybe this has something to do with the very short duration, only 30 minutes of flow-controlled ventilation in patients with pretty stiff lungs. So it might well be to see any beneficial effect that flow-controlled ventilation had to be applied for a much longer time. Now, at least in theory, which patients would benefit from this kind of ventilation? Of course, those patients who are predisposed to developing atelectasis, and maybe more in situations when there is even more increased pleural pressure, resulting in peripheral airway closure, resulting in atelectasis, and we are talking about maybe patients in steep Trendelenburg position, patients scheduled for laparoscopy, and obese patients. Now, for the first two groups, it's only in theory that they will benefit because there are no data available in literature. There is an ongoing study, but the study is not finished yet. But what with patients with obesity? We all know patients with obesity, well, they have lower and expiratory lung volume due to the weight of their thorax and the impact of their abdominal content. And you can see when flow-controlled ventilation was applied that the end expiratory lung volume and mean lung volume are significantly higher. Unfortunately, in this study, this did not result in a better oxygenation in the flow-controlled group, nor better pulmonary outcome. Now, how would we start a kind of flow-controlled ventilation? What are the ingredients to have to start a successful flow-controlled ventilation? And here it is important that you have to acknowledge it is a totally different mindset to use this kind of ventilation technique. So instead of normally setting our tidal volume and our respiratory rate, we do it quite differently. We are setting our flow, or peak, or PEEP. IE ratio is the most ideal using the 1:1 ratio. And then we just have to wait a little bit and see what this kind of settings do with your patients. And then it's time to adjust, to use some pepper and salt and to titrate your peak according to your tidal volume, titrate your flow according to your end tidal carbon dioxide, because your flow will determine respiration rate, and titrate your PEEP according to the compliance. And then it's time to wait a little bit and see what these adjustments do with your patients, and then we can start with the final touch. Titrate your flow so that you have the lowest respiratory rate, at least, but your patient must not become acidotic. So very important is that it is a totally different way of thinking and using a ventilator. You're setting your respiratory rate and you're not setting your respiratory rate and your tidal volume, but those two parameters, they are dependent upon the flow rate, upon the peak, and on the peak of your patient. We can even apply flow-controlled ventilation during lung ventilation, just with the same settings as I just have mentioned. In this study, the flow-control group is the black line, and we can see the same effects as I have mentioned before. Better oxygenation, more efficient ventilation, and maybe interesting tidal volumes that are 7 to 8 milliliters per kilo, so much higher as we normally would apply during our lung protective lung ventilation. And despite higher tidal volumes, the mechanical power was lower in the flow-controlled group. This is just a recording during retropectomy. It's not really ideal, but just to illustrate you a little bit how it works. We have inspiration flow of 12, peak 20, PEEP 5, results in a tidal volume of 320 and frequency of 19. We are going to augment our peak, so the tidal volume has to increase. It goes up 400, 460, but look what happens with the respiratory rate. We're coming from 19 and the respiratory rate is decreasing. So I just want to show you that those parameters are not fixed, they are interdependent of each other. It is a totally other way of working with your ventilator. Now, what are the benefits of flow-controlled ventilation? Now, one of the benefits is that it is associated with less dissipated energy, and according to some authors, less dissipated energy will result in less ventilator-induced lung injury. According to other authors, the energy is only very negligible and not comparable with the energy that is needed to warm up the air and to heat up the air. Also associated with less mechanical power, better compliance, it is a more efficient way of ventilating, and it has recruiting capacities. So you don't have to recruit your patient anymore because the machine will do it for you. So in that way, you have to consider flow-controlled ventilation as a kind of lung-protective ventilation. Does it mean that we have to apply it in all patients? I think that this is a bridge too far, because we also have to acknowledge that there are some disadvantages related to this kind of ventilation. It is an expensive way of ventilating your patient. It is time-consuming. You do your settings, you see what happens with your patient, you adjust, and so on and so on. When your patient has a lot of sputty, and especially when you use the trap tube, when you use tubes with very narrow lumens, then the tube will be obstructed and the ventilator will switch off. There is no patient-ventilator interaction. You need some experience to use this ventilator. It is also a noisy ventilator. I don't mind, but my surgeons, they don't like the noise of flow-controlled ventilation. So, do you have to use it in every patient? I do not think so, but it is worthwhile at least to try it in those selected cases where you expect very difficult ventilation and very difficult oxygenation. So, what are my take-home messages? What about flow-controlled ventilation? Totally differently than we are used to, so we are setting a flow peak and peep. It is a kind of ventilation technique that has recruiting capacities. There is more efficient way of ventilation. It is a lung-protective way of ventilation, but for structural implementation, I think much more randomized control trials are needed. Thank you very much.